Well, thank you so much. I am so pleased to be here today with you. My name is Rachel Seligman. I am a nurse practitioner. I worked at the University of Pennsylvania here in Philadelphia. And I don't know where everybody else is right now, but it's around 8:30. So wherever you are, thank you so much for taking time out of your busy days to join me. So the title of my speech today is Why Do I Feel Dizzy During a Migraine? And what this is meant to be is an introduction to vestibular migraine. There are a lot of really wonderful talks that are in the Headache School library on YouTube. And if you haven't already perused a lot of them, I would recommend taking some time looking at that. But I hope that you take something new away from my talk today. So I just wanted to let you know I have no disclosures at this time. And I like to start off my talks when I talk about migraine, whether it be about something as focused as vestibular migraine or something more general like treatment options for headaches. I like to start off with this quote, which is, "Pain is a more terrible lord of mankind than even death itself." This was from Albert Schweitzer, who was an Alsatian doctor as well as a pastor. And he sort of summed up the fact that there are many terrible things in this world, but pain is something that affects people so greatly. And on a semi more light note, the next slide is a quote from a band. I'm probably dating myself here, but this band, Morphine, was popular in the 1990s, and there's a song called Cure for Pain. And the lyrics basically say that someday there'll be a cure for pain, and that's the day that I can throw my drugs away, when they find a cure for pain. And it just sort of underscores the fact that we are all sort of searching for something to treat pain, whether it be psychic pain or physical pain. And I have spent my professional career, the majority of my professional career, taking care of patients with headache. And it's something I'm quite passionate about. So why does migraine matter? Before we jump into vestibular migraine, I wanted to sort of discuss why is this important, and hopefully this is something that you either know about or something that you'll be able to share with other people. And the reason that migraine matters is because of the prevalence of headache in the United States. It's estimated that 1 in 6 people in the US will experience headache within a 3-month period, and it disproportionately affects women. We also know that it disproportionately affects different racial populations. The highest rates of headache were found amongst Indigenous people, as well as high levels in white, Black, and Latinx, but proportionately higher amongst the Indigenous population. And there's also a higher burden of migraine in different groups. So age 18 to 44, people who are unemployed, people who have an income of less than $35,000, people who are disabled, as well as people who are elderly. And the global impact, so like the last slide really dealt with what the effect of headache is on the United States, but the global impact of migraine is that it's estimated 3 billion people worldwide have a headache disorder. It's the second leading cause of disability worldwide, according to the World Health Organization. And the peak prevalence is almost 20% higher in women than men. And somewhere between 2 and 4% of the population worldwide experiences headache on more than 15 days per month, which is really quite high and has an impact on life. And so when we talk about this impact on life, what is the burden of headache? There's an economic burden. It results in lost wages. It also results in higher healthcare costs, increased use of healthcare services. It causes people to miss events with family and friends. It can cause strained relationships between our loved ones who don't quite understand what's going on and why you can't participate in activities. And there's also a professional burden as well. It can interrupt education. It can cause failure to advance at work. And having chronic migraine can cause some people to leave the workforce entirely. So what is vestibular migraine? Well, the thing that's so interesting about vestibular migraine is even though it has been documented in clinical tests dating back to the 1800s, this notion of having a migraine along with vestibular symptoms, the actual diagnosis, the actual recognition that it was a disorder really didn't come around until the last 20 or so years. So you can see there are different terms that we tended to use for vestibular migraine. It was migraine-associated vertigo. There was also migraine-associated dizziness, and also migrainous vertigo. So is that really migraine? Is that really vertigo? Is it vertigo with migraine symptoms? And then they also use the term migraine-related vestibulopathy. Well, I don't know about you, but the suffix of pathy, which means suffering, sort of gives that migraine-related vestibulopathy sort of this really heavy-weighted definition. And so anyway, we don't use those terms anymore. We use vestibular migraine. And so there's a lot of things when patients start experiencing migraines along with vestibular symptoms, or if they start having these episodes of dizziness or vertigo. A lot of times patients will go actually to their primary care doctor first or go to an ENT because they think that it has something to do with the inner ear. And so this slide just sort of talks about the differential diagnosis of things that could be causing the dizziness, but are not actually vestibular migraine. So the first several ones that I have listed on here are actual disorders of their peripheral disorders. So they're disorders that deal with the inner ear, which I have a diagram there, as well as the cranial nerve 8, the vestibulocochlear nerve. And so those are peripheral, and that's BPPV, the longer name, of course, being benign paroxysmal positional vertigo, cervicogenic dizziness, which I actually see quite a bit of in my practice, Meniere's disease, vestibular neuritis, which is a irritation of that cranial nerve 8, and then the acoustic neuroma is when you have sort of a growth on that nerve. And then the last three are other things that could possibly cause dizziness or vertigo. And these ones actually are related more to a central cause, and that would be something that's found in the brain, and that would be multiple sclerosis and Chiari malformation and stroke. And for today's presentation, we're going to just pretend that we have done a full workup and have decided that balance functioning tests were normal, and an MRI was normal, and the physical exam was normal, and that what we have, in fact, is vestibular migraine. Well, there are challenges in diagnosing vestibular migraine, and the first is that the diagnosis relies mainly on clinical symptoms, as the vestibular function, as I just mentioned, is usually normal, and the physical exam may be completely normal. There might be some beats of nystagmus, some abnormal movements of the eyes, but other than that, it's a fairly normal neurological exam. The other thing is there's a broad spectrum of the way that this manifests. I mean, we're going to talk a little bit later about what is vertigo versus dizziness. And the other thing about vestibular migraine is that the head pain may or may not be present. And these are all challenges in trying to discover what vestibular, if a patient has vestibular migraine. And I can tell you in my practice, I'm referred patients from ENT all the time who've undergone an extensive workup. And then somebody asked the patient, hey, did you have a history of migraine? Have you ever had headaches in the past? And then we start to put together the pieces that, hey, maybe this is vestibular migraine, as we can't find another reason for the dizziness. So this next slide is this is the definition from the ICHD3, which is sort of the Bible of how we diagnose headaches in the headache world. And so vestibular migraine, you have to have at least 5 episodes. So that's crucial. So you can have an episode where you have vertigo or vestibular symptoms or dizziness along with your migraine, but you don't necessarily meet the criteria for having vestibular migraine unless you have had 5 episodes fulfilling the criteria afterwards. So you need to have a history of migraine with aura or migraine without aura. You need to have vestibular symptoms of moderate or severe intensity lasting between 5 minutes and 72 hours. And in the next slide, we're going to talk a little bit more about what those vestibular symptoms are. And then you also have to have at least half of the episodes with one of the 3 following features. So you either have to have 2 of the following 4 characteristics, which is unilateral location, pulsating quality, moderate or severe intensity, and aggravated by routine physical activity, or I should say like avoidance of routine physical activity as well. And then either photophobia and phonophobia or visual aura. And also we need to make sure that there's not some other reason why somebody's experiencing the dizziness, that there isn't a better diagnosis within the ICHD3 that would describe what a patient is experiencing. So I mentioned that we would talk a little bit about the vestibular symptoms. So again, these are set forth by the ICHD3. So spontaneous vertigo. So vertigo really is the sensation that something is moving. So it's either the sensation that you are moving, so that's internal vertigo. You feel like you are moving in space, even though you are actually not moving. And then there's a sense of external vertigo, which is when you feel like things around you are spinning. And that can occur just sitting, just talking. There's positional vertigo, which can occur after a change in head position. And most often patients will tell me, I was lying in bed, I rolled over, and then I just started feeling dizzy. You also have visually induced vertigo, which usually is caused by some sort of complex visual stimulus or a large moving visual stimulus. I'll share with you, I have a patient who has vestibular migraine, and he is very sensitive to repeating patterns. And if he is walking outside when it is very bright out, and I mentioned before, we live in Philadelphia, and so there's a lot of grates on the ground. And if he sees that grate with that repeating pattern and it's very bright out and he looks at it, it will trigger vestibular symptoms for him and set off a migraine. There's also head motion induced vertigo, which occurs during motion of the head, and then also head motion induced dizziness with nausea. So when we talk about vestibular symptoms, I also like to include some not so fancy terms. And part of it is you can ask a patient, and maybe you've experienced this in your own life, either with your patients or in your own personal life, that you have this sensation that things are just kind of off, but you wouldn't necessarily use the word dizzy or use the word vertigo. And so patients will report that they feel like they are spinning, that they feel like they're floating or rocking, this sort of sense that they're just constantly in motion, even though their feet are flat on the ground, tilting or swaying. They'll use the term off kilter, lightheaded, foggy, or unsteady. And so you can see it would be much sort of cleaner if we could all just say, like, okay, this is dizziness, this is vertigo, are things moving around in front of you? Do you feel like you're moving? And sometimes patients will just feel, I just feel like my head is just sort of full and I don't feel like I'm walking on ground. I feel like I'm walking on pillows. And those are symptoms that are consistent with the vestibular symptoms of vestibular migraine. So I wanted to share some facts with you. I could go into pathophysiology, and I'm going to talk a little bit about pathophysiology and why migraines occur and why we think that vestibular migraine occurs. But this is a very interesting topic to discuss. Like I said, it has only been recently that we've realized that it is its own separate entity. So the prevalence of vestibular migraine in the United States based on ICHD3 criteria is about 2.7%. It is one of the most common causes of spontaneous episodic vertigo. It is estimated that about 30 to 50% of patients with migraine also experience vertigo, dizziness, or balance issues with at least one migraine episode. And if you remember when we talked about what the diagnostic criteria are, is that you're not diagnosed with vestibular migraine until you've had 5 episodes. But at least almost half of patients have vertigo at some point. Another thing that's very interesting is that the patient may have a prior history of motion sickness. So when I'm doing a new patient visit, I always ask, like, did you have motion sickness as a child? Did you have colic as a child? Did you have persistent sort of cyclical vomiting, which sometimes it's a migraine variant that it can occur in children. The other thing that's interesting about vestibular migraine is it doesn't tend to come on until later, until mid-30s and to late 40s. It, just like migraine, it tends to occur more often in women than men, and it has been found that it does tend to run in families as well. And I didn't have enough room on the last slide, so I added some more on here. Vestibular symptoms may not occur for some time after the first onset of migraine. This is very, very important. You can have migraine for a long time. You could have migraine starting in adolescence, and then not until your 30s or your 40s where you start having these episodes of vestibular symptoms along with a migraine. And as I mentioned before, the vestibular migraine does not always occur with head pain. And that is why it can be so vexing to try to find an underlying cause for it, or to find actually a diagnosis, because patients will have these episodes of dizziness and will go seek care from primary care and from ENT when really it is more neurological in basis. The episodes of the vestibular migraine can last, or the vestibular symptoms can last from a few seconds to a few days. So it's not truly an aura symptom, if you will, because auras that start before headaches, before migraines, typically last under an hour. Vestibular symptoms also may worsen during menstruation, and probably the most important piece of this whole talk is that very few vestibular migraine specific treatments exist. We're going to talk about a lot of things that we think might work, but we need to do more research and we need to do more investigation into finding treatments that are beneficial and work for patients with vestibular migraine. So the next slide talks about some triggers for vestibular migraine. And there was a study that was done by they and others, and they asked their patients with vestibular migraine diagnoses of what was their what were their triggers. And overwhelmingly, the biggest trigger was stress. And as you see down the list of these migraine triggers, most of these migraine triggers, vestibular migraine triggers, fall into the same realm as triggers for patients with migraine without aura or with aura. And what is concerning is if you're having an episode of migraine that occurs maybe once a month with menses, or may occur 1 to 2 times per month, that is what we would term episodic. But when headaches become more frequent, when migraines become more frequent than 15 days per month, then it becomes a chronic condition. And there are certain risk factors that are associated with chronification of migraine. And those are obesity, stressful life events, alcohol overuse, hypothyroidism, viral infections, head trauma, and sleep disturbances. And so when we are trying to make sure that patients get appropriate diagnoses and appropriate treatment, what we're really trying to do is either reverse the chronification or prevent chronification from occurring. So this screen, let me see if I can get, there we go. This screen is talking about the course of what happens during a migraine. And there are 4 different sections as denoted by different colors. So in yellow, you'll see there is a blip at the beginning of the screen, and that is what the first part that occurs in the migraine, which is the aura. And actually, before we even get to the aura, we really need to talk about premonitory symptoms. So those are symptoms that are leading up into the migraine, and those can be mood changes, fatigue, cognitive changes, food cravings, and thirst. And then if you are somebody who has migraine with aura, the aura would then come next after the premonitory or the prodromal symptoms. And then in the early headache, as denoted in red, you're going to have a dull headache. You may have nasal congestion, muscle pain. And then advanced headache, that's when we get the throbbing, the unilateral pain. And then postdrome is sort of the pain can recede, but you can still continue to have fatigue and cognitive changes and muscle pain. And I added the vestibular symptoms at the top just to show you that you can get those vestibular symptoms really at any time over the course of the migraine. And if you're somebody that tends to have migraines that occur frequently and don't have a lot of time in between the episodes, it's harder for that to sort of come back down to baseline. So I told you I was going to talk a little bit about Pathophys. So when we're talking about why does a migraine start, there's a couple different theories. It seems, you know, I've been doing this for over 2 decades, and our understanding of what's causing headaches continues to change, and it allows us to get better treatment options, and it's really very exciting. But we think that there may be this hyperexcitable brain, which is this cortical spreading depression that occurs in the cortex. But then there's also this theory of the dysmodulated brain, which is that there's activation, and we see this on functional imaging, that there's activation in the brain stem that causes an irritation of the brain and causes all these symptoms to occur. All right. So cortical spreading depression, I'm just going to sort of briefly go over this. Again, I know that there's other parts of the headache school that cover this, but cortical spreading depression, there's this idea that there's this wave of electrical activity that occurs over the cortex or the outermost part of the brain. And we, in animal models, have seen that the cortical spreading depression is associated with the aura phase of migraine. And then with the idea that migraine is a brainstem disorder, we are thinking that there's a dysfunction within the brainstem nuclei that leads to this abnormal modulation of sensory processing. So, okay, that was a lot for me to just sort of spit out to you. But we think that there's the nuclei that are sort of not working well within the brainstem help to modulate different sensory input. And another piece that's really important is the thalamus. And within the thalamus, that's sort of like a major relay station for all this, for vestibular pathways. So we have information that's coming from our eyes, and we're having information that's coming from our inner ear, and we have information that's coming from proprioception, which is sort of like how we know where we are in space. And all that is sort of integrated within the thalamus. And so there are certain thalamic nuclei that we think become overly sensitized, and that creates this dysmodulation and creates the vestibular symptoms. So I'm sort of oversimplifying that, but it's a very exciting thing that we're starting to learn more about, and of course more research has to be done. And so when we're talking about what causes vestibular migraine, the underlying pathology is still not completely understood. We do think that it may result from these overlapping pathways that modulate pain and vestibular function into the brain. And we also know that many of the triggers for migraine can also cause vestibular migraine. So the question is it a subset of migraine, or is it its own headache disorder with distinct pathophysiological features? And I think we still just need to do more research to try to figure that out. So this is the part that I love to talk about: treatment options. What are we going to do to help improve the lives of our patients? And so I'm going to talk about healthy habits, acute treatments, preventive treatments, and non-pharmacologic interventions. So for healthy habits, whether you have vestibular migraine or whether you have migraine or whether you have tension-type headache, these are all really very wonderful activities that you can engage in or avoid, as the case may be, to try to improve your overall health. So hydration is a very much overlooked trigger for migraine. Diet, generally try to avoid skipping meals and trying to avoid overly processed foods as well. Exercise has been shown in clinical research to reduce the frequency and severity of migraine. And while I don't think there are any specific studies that have looked at its effect on vestibular migraine, because of so much that we do in order to treat vestibular migraine rests upon what we use to treat migraine with or without aura, it just sort of follows that that would be helpful as well. And then, like I mentioned earlier, because stress is self-reported as the leading cause or trigger of vestibular migraine, stress reduction is an important key as well. Alcohol consumption should be decreased, or should, in an ideal world, be limited greatly, because it can be a trigger, as well as cigarette and tobacco consumption. And so we're going to talk a little bit about caffeine consumption. Caffeine actually, for some people, can make them feel better and can help to sort of curtail some of their symptoms. But if you use too much of it, it can interfere with sleep, which then can make headaches worse as well. And for the next slide, we're going to talk about acute treatment. And the three ones that have been used for a long time are antihistamines, so it's meclizine or Antivert, as well as diphenhydramine. So if somebody has an acute attack of the vertigo, you're going to give them something like that. But one of the issues is it can cause dry mouth, it can cause sedation. We also use antiemetics or neuroleptics, anti-nausea medications, if you will, like metoclopramide and prochlorperazine. But again, these medications are not without their own set of side effects. They can cause sedation or they can cause restlessness. And then also for really sort of severe attacks that are limiting function greatly, we may use diazepam or lorazepam. Again, these are also sedating. You also have to be concerned, especially if people are having frequent attacks, about using benzodiazepines, because they can be habit forming. And so The last group of medications we talked about were non-specific. These are specific migraine agents that we can use for treating vestibular migraine. And so we can use triptans, which were one of the first migraine-specific acute medications out on the market. Those can help to reduce, to sort of curtail the vestibular migraine. More research has to be done on the CGRP antagonists. Those are the newer medications like rimegepant and ubrogepant. You may know them as Nurtec and as Ubrelvy. But there is thought that because there are CGRP receptors within the vestibular symptom, that if we can modulate those receptors, that we can get a benefit. And I can tell you anecdotally, I have patients that I have started on CGRP antagonists whose vestibular symptoms have improved after taking the medication. But again, more research needs to be done. And these are some acute treatment options that are older that should be proceeded with caution. There's not a lot of benefit in terms of vestibular or migraine treatment. One of those is Furoset, and the other one is just sort of the whole class of opioids. Other acute treatments that may be beneficial, and these are non-pharmacologic, ice, heat, massage, rest, sleep, relaxation exercises, again, to help with stress. And then neuromodulating devices, which I'm going to talk about a little bit more towards the end of the presentation, because both of those devices, the gammaCore and the Cephally, have been approved not only for acute treatment, but also for preventive treatment, which is very exciting. And so again, this is just sort of a recap of specific vestibular migraine treatments for the acute treatment. And then sometimes if patients get stuck into a really bad cycle, we will use a short course of prednisone, like a prednisone taper or a methylprednisolone dose pack. I sometimes will have patients take a combination of a non-steroidal anti-inflammatory along with an anti-nausea medication to try to break a cycle. We'll also use triptans for several days in a row. And I have had, again, this is more anecdotal as opposed to rooted in research, because there's not nearly enough research on vestibular migraine treatment options, but nerve blocks performed with either lidocaine or bupivacaine can be beneficial as well. So preventive treatment, if you look at the migraine preventive treatments, you have supplements, anticonvulsants, those are anti-seizure medications, the antidepressants, the antihypertensives, CGRP monoclonal antibodies, those are the injectables or the ones that are given through an infusion, and the receptor antagonists, as well as onabotulinum toxin A and the neuromodulating devices. So those are ones that we have been using for a long time to treat migraine. And so it should come as no surprise that we're using a lot of them as well to treat vestibular migraine. So sort of the hallmarks, the ones that we tend to go to first, are using the beta blockers. We'll also use tricyclic antidepressants. There's been some increasing research that has shown that SNRIs like duloxetine and venlafaxine, that's Cymbalta and Effexor, are also beneficial. We can use topiramate, valproic acid, and lamotrigine, which are all anticonvulsants. And lamotrigine, there's some evidence that shows that it's helpful for people who have vestibular symptoms without the head pain. And more research has been coming out recently that patients are responding to onabotulinum toxin A as preventive therapy. And again, there's sort of mounting evidence for the use of receptor antagonists and CGRP monoclonal antibodies for prevention, and then the neurostimulation or the neuromodulating devices. So we have supplements. Supplements have long been used. They're a good choice for a patient who wants to try something but is concerned about side effects like sedation or difficulty concentrating or issues with just sort of feeling fatigued. The anticonvulsants, again, I talked earlier about the topiramate and the valproic acid, the divalproex, and the lamotrigine. All of these are beneficial in their own right, but they do have side effects along with them. And then with the antidepressants, the tricyclic antidepressants and the SNRIs are the ones that we tend to go to the most. Again, medications do have their own side effects, usually weight gain, dry mouth, and if patients have concomitant mental health issues such as bipolar disorder, we sort of have to proceed with caution as well. And then with the beta blockers, we have to make sure that we're avoiding use in patients who have asthma or Raynaud's, patients who have decreased circulation to their fingertips or low blood pressure. And also the beta blockers can worsen depression. And then I have the CGRP monoclonal antibodies listed here. And so what was really, really very interesting is that when they did the studies of these different agents, they excluded patients with vestibular migraine from the clinical trials, right? Which would have been wonderful information to have, but I think just in order to sort of get a cleaner picture in terms of what patients were experiencing, they chose to exclude patients with vestibular migraine. And so more research has to be done, but again, there seems to be information that's coming out that's showing that these treatments can be beneficial for patients with vestibular migraine. And then the CGRP receptor antagonists, which are the oral agents, again, because they target the CGRP system and because CGRP is present in the vestibular system, we feel that they may be a viable option for patients in the future, but more research needs to be done. Which leads me to onabotulinum toxin type A, probably better known as Botox. It's a treatment where you get 155 units and 31 injection sites around the head and across the shoulders. And it has a localized effect as opposed to a systemic effect. There are multiple theories of the mechanism of action. I've been told to my face that from people that they don't think that it works, that it's just a huge placebo effect. But I can tell you from the thousands of people that I have injected that it actually is very beneficial. And again, what they're finding is that it is helping to reduce the frequency of attacks of vestibular migraine and disability from the vestibular symptoms, which is exciting. And these are just the sites that I sort of mentioned quickly. And then when we talk about non-pharmacologic treatment for vestibular migraine, vestibular therapy has long been a treatment option, which helps to sort of integrate the visual, the inner ear, and the proprioceptive input to just try to bring everything together so things are working better together, so patients are feel more secure in terms of walking and with their balance. Physical therapy can be helpful as well with some of the dizziness symptoms. Patients can have vestibular migraine, but it also can coexist with cervicogenic dizziness. So I have patients go for physical therapy, especially if we feel that part of their myofascial tension in their neck and their shoulders is contributing to their migraine picture. Biofeedback is a wonderful stress reduction treatment option. There's also a lot of research behind it that shows that it is a valuable tool in terms of helping to reduce the frequency and severity of migraines. Meditation, cognitive behavioral therapy, having vestibular symptoms, having dizziness that occurs, especially if the episodes are disabling to the point where you have to step away from work or time with your family, that has an emotional toll and an emotional cost. And so cognitive behavioral therapy can help to address underlying anxiety or anxiety that's being caused by the symptoms, by the condition itself. And then there's always a place for acupuncture. So I promised you I'd talk about the neuromodulating devices. There are currently 5 neuromodulating devices that are on the market. I chose to look just at these 2 because they have the most evidence in terms of treating vestibular migraine. So I have the pictures flip-flop, but the first one is Cephaly, which is the device that's at the bottom. And that works because it provides external stimulation to the trigeminal nerve. And because the trigeminal nerve has a role in the vestibular system, that we think that helps to reduce the symptoms of the vestibular migraine and to treat the head pain as well. And then the Gamma Core, which is a device that delivers non-invasive vagal nerve stimulation. The device gets charged up, you put a little bit of some jelly on it, you hold it up to your neck along the vagus nerve and administer pulses. And there have been case reports of improvement of vertigo and headache and nystagmus, the movement of the eyes. And more recently, there have been studies, and I have a citation at the bottom about that using that vagus nerve stimulator can be helpful during an acute vestibular migraine. The downside of both of these devices is that insurance coverage is spotty, and most patients will have to pay out of pocket for the device. If you can get your hands on one at a migraine center, at a headache center, and can try it out for yourself first, sometimes that can be helpful. But the out-of-pocket cost, I think, is one of the biggest hindrances to usage of those devices. So I wanted to say thank you. I went over a lot of information. I welcome any questions that anybody may have about this, even if it's not related to vestibular migraine. I love talking about headache. It's something that I am particularly passionate about. And I just thank you for being here today and taking time out of your schedule to listen to me talk about vestibular migraine.